that would be great.
You are.
I'm Diane.
Hi, Diane.
Nice to meet you. She's the finance coordinator like that.
Gotta have that.
Yeah, buddy.
Is our telephone hooked up? Okay. Carol? I think we should start.
Okay, all right. Thank you.
Well, welcome everybody. What a wonderful sunny day. I was just conversing here that just a week ago in Spokane, I was on a conference call with some people involved in the GCACH, and I reported it was snowing. So this is wonderful to see some sunshine and relatively low temperature. My name is Patrick Jones. For those of you who don't know me, I'm the facilitator, your fearless facilitator for the ACH going into my first year here. Yes, and here. You cannot hear.
Want to use the microphone?
Okay. So Patrick Jones, sorry about that. We are going to delve into one of our key topic areas today for the ACH, and that's opioid crisis. The Leadership Council over the last couple of years has really evolved into a sort of a learning collaborative. And I hope that when you're done with today's session, you'll take home a lot more knowledge than you had when you walked in. So just to review what's on the agenda, as always, we're a data-driven organization, so you're gonna see some data from Wes, and then we're gonna have 3 presentations. Start off with Washington State Hospital Association, and then we move on to, I think it's, who's first? Becky? Okay, Becky.
I think then we should gonna go down.
Yeah, no, Wish is going first, and then you and Everett Maroon from Walla Walla are going next. And then we'll wrap up, hopefully, with lots of good questions and some takeaways. So let's start, as we usually do, with going around the room and just quickly, and if you can't hear me without a mic, then I'll ask the people who introduce themselves to kind of shout. So let's start over in the far corner with the woman in red. Martha
Lemon, Columbia County and Garfield County Public Health.
FA Health Officer, Columbia County and Walla Walla.
Sean, Best Franklin Health District. Bethany Hickey, Best Franklin Health District.
Travis Warbaker, Best Franklin Health District.
Okay.
Kirk Williamson, Best Franklin Community Health Alliance.
Yeah, you.
Warren Walk out of Providence, Sound Lake and St. Mary's. Warren Roboto, Chief Strategy Officer for Sound Lake and St. Mary's.
Annie Caroga with Coordinated Care. Susan Middleton, Director of Quality for GCACH.
Okay.
Holly Seiler, Second Harvest.
Okay.
Lola Ayers with United Way of Debt and Finance.
Hello.
Marshall Pickett, Bennett, Franklin.
Okay.
Sarah Polidor, United Healthcare.
Welcome.
Good morning, Sherry Snow White with America. Andy Olson, with South Valley Healthcare. Janelle Brown, City of West Virginia.
Ryan Case, United Healthcare.
Marcy Durbin, People for People United. Susan Campbell from CDC Nursing.
Ed Frost, Citizens.
How you?
Eaton, volunteer with True Mountain Heart to Heart.
Okay.
He with Farm Workers Clinic.
Okay.
And Nyberg with Jackson Valley Farm Workers Clinic.
Corey White, Southeast Washington, Aging and Long-Term.
Is there anybody else on the phone?
Yeah, Larry Thompson from Arcora Foundation.
Did we lose contact with the meeting?
Yes, we lost contact for a couple of minutes. This is Sue Jetter with Prosser Medical Center.
Okay, hold off. Okay. Whoop. Who was the last one, please?
Carla Green with Prosser.
Okay.
Joyce Neeson, 211.
All right. Anybody else?
Is Whitaker, GCACH County Public Health.
What's going on here? Okay.
And Jim Jackson with Residential Care Services at DSHS.
Thank you, Jim.
Brian Sandoval, Yakima Valley Farm Workers Clinic.
Hello, Brian. Boy.
I don't know.
Okay, where were we? Right here. Okay.
Jocelyn Mendoza, yes, my neighbor is also.
Matthew Temple, Lutheran Community Services.
Ronnie Bass, our Lutheran Community Services.
Okay.
Glenn Balzan, GCACH. Kevin Martin, Kittitas County Health Network and Kittitas Valley Healthcare. Good morning, Jorge Rivera, Juliet Healthcare.
Thank you, Rose, Assistant Care.
John Montel, Richmond School District.
And why don't we just introduce staff real quickly, starting with Lauren.
I'm Lauren Johnson with Greater Columbia ACH.
Brand new. So, welcome, Lauren.
Hi, everyone. Ashleen Fernandez here. Ashleen, I'm not brand new. Welcome, everyone.
Diane Halo, Greater Columbia.
Kaylee Spence, Greater Columbia.
Carol Moser, Greater Columbia.
West Lucky, Greater Columbia. Oh, we got somebody who just came in. Would you mind introducing yourself?
I'm John Christensen, and I'm just here myself, member of the public.
That's okay. John Q. So as always, we'll start off with a brief recap from Carol about what's been going on. So the director's report, Carol.
Thank you, Patrick. I just wanted to welcome all of you for coming here this morning to hear about a very important topic to our community about the opioid crisis and what's happening statewide, what's happening regionally, and then we hope to have a robust discussion about what we should be doing as a community in response to that. And I know that we have lots of guests here, so thank you very much for attending this morning. I think that this is going to be a really great presentation, and so I'm just going to briefly hit the highlights of what we're calling now just the GCACH report. One of the things we've already mentioned is that we have several new staff. So Lauren and Diane were just hired. We're still kind of in a growth mode, just trying to accommodate, how we're going to implement the projects that we picked last year, that the board of directors picked last year. And in conjunction with that, I'm happy to announce that we finally kicked off the practice transformation work group. Mark Wakai is one of our leaders in that. Brian Sandoval, who called in on the phone, is the other leader. We have approximately 16 other primarily clinicians and community leaders from the big health systems to help us shape the way that we're going to transform our healthcare system. We also had some staff title changes. So we have named Wes as our new deputy director, very well deserved. Sam Wardell is now our director of practice transformation. And then Ruben, we added a little bit more kick to his title. So Ruben's the community and tribal engagement specialist. So you'll see Ruben out and about working with the local health improvement networks. Lauren's been doing a great job getting the word out about our meetings, and then Diane has been providing some very much needed help for Kylie in contracts and administration. Speaking of contracts, we're happy to say that 4 out of the 5 wins have received their contracts. We sent out some money last week, and so that's going well. And then we're also gearing up to have our first provider engagement funding going out. So if you've been bugged by our staff to sign up for the portal, the reason is that we want to send you some money. So those of you who sent us letters of interest, look for those funds before June. And with that, I'm going to turn this program over to Wes, who's going to be doing some introductions. And again, thank you all for coming today. Yes, Rob.
There's a June deadline of some sort for submission of projects, or what's the next phase in the GCACH distribution?
So we need everybody to get signed up in the portal so that we can send out funds. The portal is going actually down in June, I think June 19th. And so there will be a month where we can't make any payments. So that's why we're trying to get everybody signed up now. The end of July is when we have our first mid-year report due. And then as the work group decides, the priorities, the selection criteria for those providers that we're going to be contracting with, then we'll be working on those contracts and getting those signed between, now and the end of the year, really. So, are there any more specific details, Kylie? The other thing you might be thinking of, Rob, is that we're sending out a current state assessment, but we're going to ask for a quick turnaround from our providers for that, probably a 3-week turnaround. So that will be towards the middle of May. So, any other questions? Great, I will hand this over to Wes. Thank you.
So, doing a little bit of history, back in the 1990s, the pharmaceutical companies reassured the medical community that patients would not become addicted to opioid medications. During that decade, fentanyl was introduced, as well as oxycodone, which later became part of what's called OxyContin, a time-released medication. Today, about 115 people die every day from opioid abuse. Let's go to slide 3. Nationally, the statistics are nothing short of staggering. In the 2016, 15 to 16 timeframe, 42,249 people died. That's more than gun violence. That's more than motor vehicle accidents. Opioids are now the #1 killer of men under the age of 50. In just 1 year, the percent increase in the opioid death rate, just 1 year, increased by 28%. On top of that, the increase in fatal opioid overdoses among Latinos increased by 1/3. Native Americans weren't spared from this as well. Fatal opioid overdoses for that group increased by 15%. And the increase in fatal synthetic opioid overdoses increased by 100%. Fatal synthetic opioids include fentanyl and carbafentanil. So the Department of Health has created this great website that tracks what's going on statewide, county by county. The information here is a bit dated. The last refresh was for the fourth quarter of 2016. But what we've done is taken a few graphs to just show what's going on with the ACH. That time series on top relates to the 9 counties that are in our service area. It's a little hard to differentiate between Asotin and Garfield County because they're both orange, but needless to say, they're both on top. What we're seeing here is the trend for the state of Washington for patients with any opioid prescription. Garfield County had the highest rate of opioid prescriptions within Washington state. Asotin and Columbia were on its tails. Now, I want to caution you that these are rates. Those counties tend to have smaller populations. Garfield, Martha, what are you saying? Not to meant to pick on you. Garfield County only has around 2,000 people. So again, these are rates per 1,000. So even small numbers can affect this. But needless to say, there are some trends going on here. As you can see in that map, in the bottom right-hand corner, Garfield County is darkened there because of its high rate. Let's go to the next slide. This looks at patients with chronic opioid use, which is defined as having a prescription for greater than 60 days. Again, Garfield and Columbia counties had the 2 highest rates in the state. Again, if you look at the map, that bottom right corner tends to be darker. Asotin is also very dark. Now, Benton County, Lauren, do you have a pointer there? So Benton County, which is right here, it's a little hard to tell there, but that county is also darkened as well. And relative to the state average, it is much higher. Benton County is worth considering because the population here across the river is very high. So when we talk about rates in that county, it's significant. Let's go to the next slide. So here are the rates for patients that have both concurrent opioid and sedative prescriptions. This is a measure that we're tracking through the ACH as one of our pay-for-performance measures. Again, Columbia, Garfield, and Asotin top off the list here statewide. And again, you can see how dark those areas are. Let's go to the final slide for this. So this is fatal drug overdoses. This is really the final outcome measure, literally. And as we can see here, Garfield has the highest rate in the state. But again, we're seeing in this particular area within the heart of the ACH that we have some issues to tackle. So it's fortunate that we have this project work to deal with. The state has assigned this as being a required project area. And there's lots of things that are going to be underway, as we're going to hear later on from Becky and from Everett. We're also going to hear more from the Washington State Hospital Association about what they're doing with our hospitals statewide, and there could be opportunities for collaboration there. Let's go to the last slide. This particular slide should be familiar. This is the Christmas tree. This is a little bit of a different view. The one that we typically show is a compressed Christmas tree. This one actually breaks out the age cohorts and the different cohorts for some of these groups. So these measures right here in child and adolescent access to primary care are typically rolled up into one measure. We've broken them out here. What we've done is highlight in red those measures that pertain to opioid use. We see here that follow-up after discharge from the emergency department for drug dependence, which could include either a diagnosis of opioid or possibly an overdose. That is one of our measures. We want to try to achieve a follow-up with primary care within 7 days. That's the goal, but we're also tracking follow-up care within 30 days. These little arrows here talk about the directional goals. So for those 2 measures, we want to increase those measures in terms of follow-up. Another measure are patients on high-dose chronic opioid therapy by varying thresholds. We want to see a decrease in that. That's potentially a risk factor. Patients with concurrent sedative and opioid prescriptions, that was one of the charts that we looked at here just a second ago. That's also an area that we want to see a decrease in as well. And finally, substance use disorder treatment penetration is an access measure. And so individuals who have a diagnosis that relates to opioid abuse, we want to make sure that they have access to a provider at the very least once a year. So we want to see positive performance there and an increase with that measure. Does anybody have any questions about those measures? Of course, there's a lot of other measures here that we're trying to achieve some positive performance over, but these ones with opioids obviously have some relevance for today. John.
What's the significance of GTG versus iOS?
That's a long conversation that talks about what type of, how we score these measures. So regardless of what these measures are, we have to score an improvement, either to reduce a measure with a downward red arrow or to increase a measure with a positive up arrow. This is just the strategy that healthcare authority has put upon us. GTG means gap to goal. iOS means improvement over self. For example, improvement over self means that we have to achieve a 1.9% improvement from our baseline score. Our baseline score. I won't go into gap to goal other than to say we're being compared to a benchmark and we have to show some improvement towards that benchmark rate, which is typically a HEDIS rate.
Thank you.
Sure.
Wes, this is Liz from Kittitas County.
Hey, Liz.
So my question is how current is the data that we can collect on these measures?
Well, as you can see from the database, it is a bit lagged. We are trying to come up with some ways to collect more timely measure. It's a complicated process because we're dealing with data and IT systems. So this is still some work that we're trying to flesh out as to how we're going to be collecting this information from our providers. It may mean purchasing an IT platform such as CMT's Pre-Manage, which also has the EDDI program. There are some other tools available on the market. They're all very expensive. Implementation is also expensive and time consuming. It involves feeds, electronic feeds into provider organizations. So there's more work to be done around that, and we don't have a final answer to that right now. Barbara.
I'm assuming metric number, I think it's 27, the substance use disorder is for all substances, not just opioids. Is that correct? Alcohol, et cetera.
I believe so, Barbara. I don't have that definition in front of me. I know it at least includes opioids, but I think you're right. I think it might be all substances. And we can follow up with you to tell you for sure.
So Wes, here's a question from the facilitator. Over the 9 counties, so you highlighted the 3 counties in Southeast Washington, but over the 9 counties, how do we fare relative to the state by these measures? Are we generally above average, worse off? Are we average? Did you have a chance to look at that?
So to get at that information, what we really want to try to find out are our baselines across these measures. And for right now, previously when our practice transformation work group got together, we did not have baseline data. Healthcare Authority has released baseline data, which again, we have available and we haven't analyzed, but in a future meeting of that group and probably this group, we'll present some information to show where we stand relative to the state. Again, because the populations of those 3 counties in that map were so small, if you do a weighted average, it's kind of hard to tell whether we're above average or at average with the state of Washington. But we'll be getting more information and bringing it back to this group. I'm going to give this back to Patrick so we can move on to our Washington State Hospital Association presentation.
In the course of the morning, if you have more questions about Wes that sort of pop up, we'll have a chance at the end to talk about those. So if you would like to come forward, Ian and Trish, we have 2 representatives from one of the most important association for health advancement in our state, Washington State Hospital Association, or WSHA. And we're going to get a presentation today about WSHA's work on this scourge, not only in the ACH, but statewide. Just a brief intro for Trish. Trish is the Director of Quality and Performance Improvement for Patient Safety and she comes to us, is at University of North Carolina, UNC, and then must be some Canadian roots here, University of Alberta with a bachelor's in nursing. All right, got a fellow Canuck here in the room. Her co-presenter is Ian Corbidge. Ian is the policy director for patient safety on the government affairs team, and he holds a master's of public health from George Washington and a bachelor's of nursing from PLU. So.
Yes, go right.
Okay, you got.
We got support.
Yeah. Exactly. You got another Lutheran here. So, are you starting, Trish?
I am.
Okay.
So thank you very much for the introduction and the invitation to join you this morning here in the Greater Columbia area. We're excited to explore some potential opportunities as we continue to advance some strategies that the Washington State Hospital Association, along with the Washington State Medical Association, have been jointly preparing and advancing these past years. So today we will cover an overview of our joint association's work on opioids, then share with you what we are going to be doing moving forward, our policy and clinical efforts to also change prescribing practices across the state, along with seeking methods through our members, through either physicians and or member facilities to increase access to treatment, ultimately stopping our overdose deaths that are occurring across the state. But most importantly, we're here today to look for opportunities for collaboration with this community and expand that across other ACHs over this year. So WISHA and WISMA have come together under a joint task force and at the request of our members to provide leadership and guidance to spread the national guidelines around prescribing to influence practice changes, all in the sphere, the greater sphere that I've represented here of accountability. And how we're hoping to achieve that is through some programs that we'll highlight in a minute. So Ian, I think I'm going to hand that over to you.
Right. So good morning, everyone. Again, Ian Corbidge with the State Hospital Association. And I guess maybe doing a quick sound check. My daughter has profound hearing loss and she wears a Rogers system. I saw someone with a Rogers system here today. So if we're not loud enough or you want me to wear the lapel, happy to do that. So just tell me to increase if we need to. So again, Trish, thank you very much for teeing things up. And I think this is really where we're hoping to kind of frame some of the conversations that we have been focused on, and again, really seek feedback from this community. But before we do dive into that, I just wanted to give this group a sense of kind of where we've been and kind of our focus area over the past couple years. So I should note that the Hospital Association and the Medical Association have had a long-standing body of work termed ER is for emergencies, essentially trying to make sure that individuals who are showing up to our hospital emergency departments are there for valid reasons, and that if those patients need to have been seen in another place, that we have the right system in place to make sure that those patients are seen in the appropriate level of care. A component of ER for emergencies was looking to reduce the rate of opioid prescriptions from ED providers. Again, initiating back in the 2008-2009 timeframe, and I would say the early success within the opioid component of ER for emergencies was a near immediate 24% reduction in opioid prescriptions for the Medicaid population. And the way that we did that, and we're going to look to emulate that in some other work that I'm going to talk about here in a bit, was simply providing feedback reports to ED providers on the rate of your opioid prescriptions compared to your peers. So essentially data being used as a meaningful way to leverage kind of the collective power of quality improvement, and that the provider community is very competitive. And when they saw themselves on the very end of the right end of the bell curve, that's not where they wanted to be. And so they ratcheted back the rate of opioid prescriptions. So again, a key opportunity to leverage data to really drive change within our community. transitioning here a little bit, talking about legislation. Again, a really strong collaborative with our State Department of Health and the State Medical Association over the past couple legislative sessions to really drive forward meaningful policy in our state to look to address the opioid crisis. I will say kind of the most pivotal, or I'd say most recent legislation that I would like to talk about briefly was from the 2017 session. And there was really, I think, two key components that came out of that. And I think actually two key components where Washington State is really taking a lead across the nation in terms of trying to address the opioid crisis. So just taking a little bit deeper dive, I guess the data indicates that patients who have a near fatal overdose event, 90% of those patients have a continuation of the same drug, an opioid that almost killed them. And it's 90+%, it's like 92 or 93. It means a massively high number. And the reality is that providers don't have any information to let them know that that patient almost died from an overdose event. So here in Washington State, from the 2017 legislation, we're actually standing up an electronic overdose event notification system. It's running off the backbone of the EDI system, the Emergency Department Information Exchange platform, that's in all hospital emergency departments. And essentially, if you're a patient who has an overdose event, you show up here to a hospital ED via electronic platform. That system will identify that patient, and then it's going to send notifications to that patient's primary care provider and any prescriber of an opiate. So again, trying to make sure that clinicians have information in their hands to act meaningfully in terms of getting that patient connected to treatment services, connecting with other providers who may have prescribed an opiate, and then also rethinking their course of treatment if they have prescribed an opioid. So again, I think a key piece of legislation that we are leading on across the nation. The other component from the 2017 bill that I will talk about in more depth later on is actually getting the State Hospital Association access to data in our state drug prescription monitoring program. And so, Wes did a great job of teeing up some great state data that we have. Some of that, I think, was from our state drug prescription monitoring program. But at the Hospital Association, in collaboration with DOH and the Medical Association, we're getting access to that information to use it in a more nuanced way and really work with our provider community. And I'll dive deeper into that in a little bit. I guess in summary of our 2018 session, and I'm not sure how many of you are policy wonks or follow our state legislative process closely. There were over 10+ opioid-related bills that were introduced this session. Unfortunately, very few, only one made it forward. And the governor's comprehensive opioid package was one of those bills that did not advance, unfortunately. So what we did end up with was a bill that I think is tremendously meaningful, standing up a state drug take-back program that will be funded by pharma. Again, a huge win in our state. Obviously, more needs to be done, but I think a take-back program is a key solution to addressing the opioid crisis. And then while a number of policy bills did not advance, there definitely were funds identified to help address this crisis, about $16.5 million. So still meaningful efforts that did come out of the 2018 session. So taking a step back in terms of kind of where WISH's other focus has been, as Trish noted, there's been a lot of work in terms of trying to support clinical practice change within our provider community. That work has been ongoing for a number of years, and then just ongoing advocacy efforts, and I really say this at the federal level as well. So transitioning then, I guess the past slide is where we have been. I think I want to talk about kind of where we are going now. I imagine that this map looks very familiar to a number of you, so I don't have to go into detail about it, but I would like to spend just a couple of seconds talking about what this map meant to our membership, so 107 hospitals across the state. I think we heard very clearly early on from our membership in that these geographic boundaries may be meaningful for the state, they may be meaningful for ACHs, they may not be that meaningful for patients who are going to cross these artificial geographic boundaries. So if we're going to do right by patients, their strong ask was to make sure that the system was aligned and that no matter where a patient went, they were going to get the same level of care. I think the other component within that we heard from our membership is that many of our members are actually systems. So they have hospitals in a number of these ACHs, and their ask was very clear in that rather than all of our different hospitals having to focus on different aspects in terms of trying to address the opioid crisis, trying to improve behavioral health, we should really make sure that the system is aligned. So when we're implementing one thing in one hospital in the Southwest, it's going to be aligned with what's going on in the Northeast. So again, trying to make sure that there is alignment for, I think, efficiency's sake, but also, again, to make sure that we are doing right by patients. And I'd say this kind of then kicks us off to where the association has been in conversation with our membership and the ACHs over the past couple of months in terms of where are those opportunities. So this thing kind of brings us to a convening effort that the association did, again, with clinical thought leaders across the state, with ACH participants, to think about what are the opportunities for hospitals and healthcare systems to have a meaningful role in terms of trying to address the opioid crisis. And I would say after a number of lengthy meetings with a number of different individuals and many different opinions, we kind of narrowed the list down to 5 or 6 meaningful elements that we thought we could advance in the state. And then from that point, I think we then kind of further thought on it and said, you know, where are those kind of ripe opportunities that we could take meaningful action now? And I would say it's the 3 that are highlighted here. So really trying to work on overdose prevention, expanding access to treatment, and improving opioid prescribing. I should note there's a URL link at the bottom, and the document, while it's fuzzy from my perspective here, you obviously can't read the text up there, but if you go to the URL link, there is a 25, I think, page document that was really intended to provide some direction or opportunities for ACHs to consider in terms of addressing the opioid crisis. So then transitioning here, so I guess now we're going to take at least, 5 or 7 minutes, I think, to take a deeper dive into really what's kind of within the nuance of these 3 potential models or areas that we would like to explore. And then, thinking about what is that collaborative synergy between, hospitals, health systems, and ACHs. So I should note that the patient safety team, of which Trish is on, has a CMS contract, and you'll see the AIM up in blue is really the metric. It's a broad metric that our patient safety team is working to meet for our CMS contract. So that AIM runs throughout all of our work. I would also say it's a really high-level metric, so it sometimes doesn't provide a lot of value. So we're drilling down here more in terms of kind of what we transitioned from the last slide around overdose prevention. And so again, want to take a deeper dive into these 3 strategies. So naloxone dispensing in the ED, for those who are not familiar with naloxone, I would say it's almost a drug to bring you back from the dead, if you will. An individual who's had an overdose event, their respiratory rate is suppressing, you're able to give them naloxone and essentially almost immediately bring them back to life. It's an amazing drug, and I know it's something that has been getting a lot of attention in the community as more and more EMS, police force, et cetera, are carrying this. From our standpoint, we see a number of patients who have had an overdose event or actively overdosing, showing up in our hospital emergency departments. They receive emergency departments. And then unfortunately, oftentimes these patients leave without kind of any further care or follow-up. And it's not because the clinicians weren't trying to, patients can be resistant, wanting to leave, et cetera. But I think we really saw on our end, it's a key opportunity when that patient is in the hospital ED, there's somewhat of a captive audience, if you will, sitting on the hospital gurney, to try to provide some education to that patient in terms of if you were to experience an overdose event again, or if your friend were to experience an overdose event again, gosh, sure, it would be great if you had naloxone on your person to make sure that someone could administer it for you, or you could administer it to someone else. So we saw a prime opportunity for a kind of an educational platform within the emergency department, and also a really unique opportunity of, rather than writing a prescription for a patient, hey, go fill this naloxone prescription at the pharmacy down the way, and that provider hoping that that patient will actually follow through on that or have the money to do that. Wouldn't it be great if we just gave them naloxone in the ED right now, and making sure that before they left our emergency room, they had this on their person? And there are hospitals in the state who are doing this now. We have worked hard, I would say, the last couple months to get clarity at a state level that there's no state laws that would preclude us from doing this, because there was some potential conflict in state statute that's not there. And we've had the state agree upon that.
And so we are really now looking to move forward, given that some of our members are already doing this. We think this is a key platform to make sure that we're reducing overdose events in our community, that we will be working with our hospital members to really focus on policies and procedures to make sure that in their emergency departments, they are dispensing naloxone to patients who've had an overdose event or have a substance use disorder. And I think this is a unique opportunity, again, for ACHs and hospitals and health systems to start collaborating together. I mean, you can think about, there could be various models. If a hospital were to implement a program, the ACH would provide support, et cetera. You could base things on a number of metrics, how many naloxone actual dispenses you've done, et cetera. So, again, I think unique opportunity for a partnership between ACHs and hospitals, and a key way to help reduce overdose death in our community. Anything else, Trish?
Great.
All right. And I guess I don't think we noted, so Trish is actually relatively new to our team. So in preparing for this, I've been working on this for a number of years. So I said I'd be happy to kind of help take the lead as Trish is getting up to speed. So jump in if you have anything that I missed or want additional insight. So expanding access to medication-assisted treatment or therapy for those who are not aware of what this is, again, it's somewhat of an interesting name in terms of we don't call other medications, medication-assisted treatment, it's just the medication. But essentially, medication-assisted treatment is a therapy to help someone wane off their addictive tendencies to an opioid. Kind of basing off the similar platform that I just talked about, again, a patient shows up into your hospital emergency department, either they've had an overdose event or they have a diagnosis for substance use disorder. Rather than us treating that emergent event right now and discharging them and saying, okay, well, you should go seek community treatment, it's going to be beneficial for you, wouldn't it make sense, again, they're a captive audience in our hospital ED, they're sitting on the gurney, let's start treatment right now. And so this is, I think, very much of what this project is focused on. We have some hospitals are already doing this and piloting it within their community. So essentially what it would be is, you're my patient, you're sitting on the gurney, we've treated all your other emergent, situations at that time, but I would then want to talk to you about treatment, and I want to make sure that I'm initiating treatment right now, and then I'm going to give you a 2-day supply before you leave my ED, and then before you leave the ED, I'm going to make sure that you have a care coordinator who's going to be working with you, and that you have an appointment to a community provider who is going to make sure that you are getting your prescription and your treatment for MAT in the community. And so, I think somewhat of we all think, well, yeah, gosh, that should be happening. That's the way care should be delivered. Unfortunately, I think we probably also acknowledge that we don't have all of those components are easily in place across the state in terms of care coordinators, community providers who are available to actually prescribe MAT. And so this is where I think Carol West and I were talking earlier. I think this is a unique opportunity for hospitals and health systems to really work with ACHs and say, hospitals, we probably can do a really good job in the ED setting. We can make sure that we're initiating treatment, providing the education, but we probably don't have the resources for that care coordination, or we don't know where the community providers are who are actually prescribing MAT. So how can hospitals and the ACHs work together to make sure that when that patient leaves the ED, they've got all the resources that are wrapped around them to make sure that they are successful when they do leave. I also think for this one, it would be a tremendous opportunity for us as a state to think about, as hospitals start to roll this out, how are we collecting or how are we measuring when events don't happen? So, again, that patient leaves the ED, are they actually going to the appointment? How long are they doing their treatment for? So I think, making sure that we're capturing kind of missed opportunities at ACH levels, and then also making sure that that information is, collected and aggregated at a state level so that we can come back to policymakers in Olympia or to the health authority and say, hey, we've got this great model, but there's some key kind of resources or connections that aren't happening. What do we need to do? So I won't go into a lot of the data because I think Wes teed it up nicely. I think this graph here, if you were to look at it kind of in summary, really says the longer time frame that an individual is taking an opioid, the greater percentage chance that they will be taking that opioid either 1 or 3 years down the pathway. And it's pretty significant, just, 15-day supply, you're looking at a 25 or 30% chance that you're going to be taking that within 1 year and a little bit less for 3 years. So I think this is striking. And I think something that has really hit clinicians hard, clinical people hard, and that they didn't really realize how addictive this substance was. And so that, I guess, this data feeds directly kind of into this next, I think, area of work that WISH is looking to work at, that is really focused on how are we making sure that providers are aware and informed of their prescribing practices and making meaningful change to reduce unnecessary opioid prescribing. And the work here, again, kind of tees back into the dialogue that I noted around ER for emergencies, where, you know, simply providing data in a uniform way, in a structured way, to support quality improvement at the local level, i.e. the hospital, or at a geographic level, is tremendously meaningful in terms of moving the needle. So I think you can see up here opioid feedback reports. As I talked about, the state has a very strong state drug prescription monitoring program. It now has and will be rolling out more capabilities to provide direct provider feedback reports to individual providers to say, hey, provider, this is how you stack up in terms of your prescribing practices to your peers. So tremendously helpful information. That does require engagement and commitment from that individual provider to go look at that information. I should also note that the State Department of Health is going to be providing some notifications directly from the department to those who are really high prescribers to say, hey, we don't feel like we can sit back and have you come to our system. We need to make sure that we're following up and speaking to you. So some great work going on at the state level. But I think really want to focus in today kind of what the Medical Association, Hospital Association, and collaboration with DOH are hoping to do. So as I noted in the 2017 legislative session, WISHA got access to PMP data. We are going to be using that data directly with our membership and working with individual hospitals, working with individual chief medical officers to identify the prescribers within a particular facility, take that list, run it against the PMP data, and kick back information to the hospital and chief medical officer in terms of this is how your individual hospital stacks up in terms of your hospital prescribing practices. This is how you compare with your peers in your similar, geographic community. And these are your individual providers within your system and their own prescribing practices. And so it will identify those providers who are, again, on the right end of the bell curve, who have very high prescribing rates. And that information will be used in targeted quality improvement forums that the Hospital and Medical Association convene with our chief medical officers. It's intended to be information that the CMO can act on in terms of saying, we may have a problem here. This doesn't tell me the entire picture. I'm going to have to go have some individual conversations with these providers to say, is there a legitimate reason? Maybe I didn't know that you were, you're dealing with end of life patients and you have, or cancer patients, and you have a legitimate reason. And we will have some of that data. But again, it's supposed to be a start of a conversation to make sure that hospitals and health systems are working with their provider community to be aware of their prescribing practices, to make sure that we are implementing policies and procedures to follow state and federal opioid prescribing guidelines, and then making sure that we have quality improvement efforts in place to really ratchet down when prescribing is inappropriate or in excess. So I think this is a unique opportunity, and where we've been envisioning, I think, a really strong partnership with ACHs, hospitals, and associations to think about how can we come together in a protected space, because this information is protected, but how can we come together in a protected space to identify opportunities for improvement, to have data to measure where our baseline is, and then to work to improve our prescribing practices within our community, and to be able to measure it over time. And at the association, we'll be getting quarterly updates of the PMP data, so we'll be able to, I think, kick back meaningful information to the provider community and hope to see some real change in a short time frame. I should check, I think, Trish, we're going to get data, the first PMP data dump in this quarter. A couple weeks. So I think we're really excited to, for the first time, get this information and to start using it in a meaningful way. Yeah, yes, please, question. Yeah, you should. I should have known that early on. Just ask away.
So in my experience, it's a lot of the independent practitioners that are not under a health system that is the problem. So who's going to oversee that? Is that the WISMA, or is that, who's going to do that?
So excellent.
Can you repeat the question?
Yeah. So just to repeat the question, it was noted that it may be a lot of the independent practitioners who are not part of the system who may have high prescribing rates. I think it's an excellent point, and your kind of response to the question was exactly, we are working with WISMA, so hoping that the Medical Association can help make sure that they're bringing their members to this collaborative. We haven't fully thought about it, but your question brings also up a good point of, how do we work with the dental community? So I think an opportunity to work with the Dental Association to say, again, we have a legal structure to use this data in a meaningful way, in a protected way for quality improvement. We can bring other partners to the table to be part of those conversations. And so I think thinking broadly about, are we capturing the right people and do we have the right people at the table? So I think excellent point. Yes, sir, question.
Only one ended up being law. Can you share with us the basic resistance in the legislature to the opioid crisis bills that were there?
Yeah, so the question was, going back to an earlier slide, I noted that there were 10 plus opioid bills this session and that really only one advanced. Some number of the 10 were that there were same bills introduced in the House and the Senate. So there some duplicative bills, if you will. I would say the question was, what is the resistance or hesitancy from elected officials to do something on opioids? I would say, I think there is a ton of interest and commitment from elected officials in addressing this issue. This legislative session was a short session, and so things need to wrap up in 60 days. And so I think elected officials ran into that deadline, which I think caught a number of people off guard, if you will. And unfortunately, the comprehensive package that was part of the governor's opioid omnibus bill had an amendment hung on to the bill at the very end that many elected officials didn't want to vote on the bill with this amendment attached to it. And the amendment was regard to safe injection sites, which is a very controversial issue within this state and I think other states. And unfortunately, elected officials did not want to take a vote on the bill due to that reason, which I think is unfortunate in terms of the state losing out on a lot of opportunities. I will say, we work closely with the governor's office and other stakeholders on that bill. I think there's full commitment to bring it back in the 2019 session. And there's also efforts underway to say the policy bill didn't advance. What can we do as a community outside of the legislative process to move things forward? So I think there's, again, it's unfortunate. It would have been a great opportunity for our state, and I hope we get more opportunities in 2019. Yes.
So I know that we're talking about prescription opioid use, but in my experience working with the at-large public on navigating those services and getting the help that they need, mental health, co-occurring or chronic pain issues. I'm sorry. So the heroin use and the difference between the heroin versus the medication that's prescribed. What I know from experience is that they'll get one, sell that to get the other. And that's an issue too that's not being addressed that I hear. I'm not hearing this. So I'm just bringing this up as this is also part of that issue. And so people that are experiencing homelessness, people that have these chronic conditions or mental health issues, there is that co-occurring piece. And unfortunately, when we're looking at this is the avenue, but the supports that come aren't being discussed. If it's those things, and they still become a health risk and a high utilizer of the ED because of the chronic health conditions that occur after that. So how are we addressing that?
Yeah, so I will repeat it. I won't repeat the whole thing. But no, I think you had an excellent point. I think it boils down to, and there's been actually some articles recently on this, we have two epidemics, one being the prescription opioid epidemic and one the illicit opioid market. So it is a very valid point. Again, from a hospital association standpoint, the medical association, I think we focused on the areas where we thought we could have a meaningful contribution to this work. And so it is healthcare centric in terms of our approach. But I think you're spot on. And I would say, I think it's a role for the ACHs to say, we need to be working with our law enforcement community, our judicial community, to make sure that we have similar and strong interventions to make sure that we're addressing kind of the illicit side of the problem as well. I will also say, research seems to somewhat be changing, but I think if you look at kind of historical research, it shows that the initiation into heroin was likely caused by a pathway of an original legitimate opioid prescription. So I think trying to do our part in ratcheting down the unnecessary or inappropriate opioid prescriptions will have an impact on that illicit market. But it will take time, and I think there'll also be some unintended consequences as the rate of prescription opioids kind of dwindles. I think patients may turn, or individuals may turn to other avenues to secure drugs. And if you look at our state data, since 2008 or 2009, we've been doing a good job at a steady reduction of overdose deaths from prescription opioids, but it's all been backfilled by overdose deaths from heroin. So we've been making progress on the prescription side, but unfortunately, heroin and the deaths caused by that are backfilling all of our progress. So I think absolutely meaningful thing. And I don't work in law enforcement, but I hope that ACHs are working with our law enforcement partners and our judicial partners to address your very point. Sorry. Yeah. And then you. Yes.
Does this relate to what you were discussing earlier concerning getting information from patients when they come into the hospital? So if somebody's there for an overdose, you can find out whether it's due to a prescription opioid or illicit opioids, and advise them, based on that.
Yeah, so I guess the question is, as I noted, we're standing up an overdose identification program in our state, and the question was, are we able to, I think, discern whether that was a prescription-related overdose event or from an illicit drug? Depending on the facility and the level of, I think, toxicology research and digging into they might be able to do that. I would say from the initial coding set, it'll just indicate that an overdose event happened. And then email or send notifications to that patient's providers. I think the hope is, and the language in terms of the draft notifications, it talks about both prescription and illicit drugs and efforts to, apply treatment or address both of those issues. But unfortunately, the system will not have the nuance to drill down to that specific issue at this moment. I think we're all understanding that. I think we might be the first state in the nation to do this. So it's going to be some learning curve with this electronic platform, but I think there's a lot of commitment to over time, doing some rapid cycle improvement until we dial it in. That's in a meaningful way. I think, sorry, there was a question back there.
I was stemming the question, and the stemming is kind of, it's going to be provocative, the discourse. It's actually dangerous to begin to dissect things as a prescription opioid epidemic or a street heroin epidemic or a methamphetamine. We have a huge drug problem.
Yep.
The drug flavor of this season happens to be opioid. There's a lot of information that supports that. So I try to caution myself on that because I begin to dissect things apart, and then I cannot narrow my thinking and solution focus activity. I love what you guys have presented, and I think there's a lot of potential to that. The question. Who's a professional in the ER who takes the time to spend time with the patient and provide this sort of motivation and this discourse about, hey, I'm going to send you home with a list of referrals, but I'm going to be calling you at home also to make sure you follow those referrals, and I'm going to send a couple of cans of Narcan with you in case of. Who does that discourse?
So excellent question. The question is, how do we actually implement some of the recommendations in terms of, who has time in a busy ED to do the patient education to make sure that naloxone is being dispensed? It is an excellent question. I think that's where we have some hospitals who are piloting right now, and I think it's been a mix, largely probably the ED nurse. And I think some hospitals also do have patient educators in their ED, depending on the time of day. very well could be a physician. I would say for some of these practices, given that we do have pilots going on, I think we're trying to, learn from our members of what they think is optimal and try to provide, recommendations of what facilities could consider. But I think leaving it also open for people to be innovative in their thinking. If you have a pharmacist in your ED, they're well placed to do that as well. So I think there's a number of members on the care team who could provide that. Again, I think there's an opportunity for ACHs to work with their hospitals to say, if the ACHs are contracting for care coordinators, how are they linking with in the ED? What role can they play? So I think it will require a number of professions to come together. I think require hospitals to think about their policies in terms of staff available and who's well positioned to do this. And then again, the link with the ACHs. So, yeah. Yes, in back.
Is there initiative to get these hospitals to do this? And two, is there a way to implement some sort of format where they can't release for discharge without ticking off that it's done?
I guess the first question was maybe kind of like what incentive or structures out there to compel facilities to do this? I think one, at the hospital association side, we're looking to use our convening power and our quality improvement work with our membership through our patient safety team to really drive this through our membership. I think the other incentive structure is for us to think about kind of how do we create that relationship and payment model with the ACHs so that providers within institutions who are doing this are getting some compensation or acknowledgement that this is taking place. Depending on what metrics you set up, obviously the flow of monies, et cetera, would come from the ACH2 providers. So I think that is one incentive structure. Also, just doing the right thing by our patients in our community, I think, is another that all of our members strive to make sure that we are improving care. And I would say at a board level, at least within the hospital association, the medical association, this is a key item that our board members want us to be addressing and improving outcomes in care in our community. So it will be a huge focus of the association and has been. In terms of a requirement to check, we haven't thought about that. I would say I don't think we're looking at any requirement at this time. I think our hope is that, again, via the ACH model and working with hospitals, that will create kind of the meaningful carrot structure to move people in this direction. And I guess if that's not successful, other policy makers may have different ideas. So, and maybe I just do want a quick time check because I have been talking for a while, and I don't want to take up too much time, but
I think we're good because some of the questions you're dealing with, Ian, are the questions we'd have later. So it's better to have you answer them than try to figure out what you would have said. So did Becky have a hand up? And then Ronnie, Becky, do you have something to?
I just had a couple comments on a few of the questions. One, that you asked about how will they know if it's illicit or not, and what Miguel said was right on. But there can also be some investigative work on the part of the prescriber. Obviously, if they come in positive for opioids and you don't see it on the P&P as prescribed, then they're taking it illicitly. So that's kind of a little bit of a no-brainer. But somebody's got to do that investigation work. Another piece is some of this management and addressing overdoses lies within the MCOs too, because there is some functionality within EDDI that allows MCOs to contract the work for overdose management, which is something we're doing, which is an immediate notification when someone presents to the ED. So some of the responsibility lies outside of the ED.
Absolutely. Couldn't agree more. I like the point about MCOs being a key partner in this process. It's, I don't think I mentioned that, but you are absolutely right. I mean, the MCOs have a huge role in this. And again, kind of, I think, what is this collaborative structure? So I think you mentioned a structure that you guys are working on. I think, the question is how do we meld all these really good efforts that are underway that may be siloed or we don't know about what each other are working on and kind of bring together a comprehensive system for patients.
And the STR Pathfinder grant that's coming, that was assigned on the west side of the state. We did get a STR Pathfinder where we have peer counselors, and that's who will be doing a lot of the education and outreach, in my opinion.
Something we passed opioid, rural opioid.
There's
vehicle is coming out a little bit, a few weeks from now. So.
Can you talk about that in your presentations a bit?
Sure.
Okay, yes.
Just to piggyback off of what Becky said, is that
I know that United Healthcare has the care coordinators involved, and I'm believing coordinating care as well does.
Most of them all have health home coordinators.
Right, where they come in and they see you, or they come to you wherever you're at. And that would be a good pathway to get the support behind things, because one of the things that I found working with the general public and the capacity that I did prior to working for Blueprint was to navigate people into systems of care so that the co-occurring mental health and addiction was supported, and they were supported in their seeking care services. For the persons that had health issues that were like end of life stuff and chronic pain, heart, and kidney, and liver disease, things like that, diabetic in that later stage that were homeless. I found that they were utilizing illicit drugs to medicate, but getting them into systems of care and supporting them through their systems of care. Without that piece, when we're talking peer support, community health workers, which I'm both, it gives them an added support that they don't normally have, because by that time, all of their natural supports have fallen off. And so why should I care if nobody else cares? And then it just flips on that slippery slope back down. So giving that support through those avenues that Becky's talking about, as well as through the insurance umbrella, and having that coordinator come out and say, hey, I'm a care coordinator, I really want to see you successful. And that goes a long way.
Yep. Absolutely. I think so. Talking about the importance of care coordinators, you couldn't be more right. And I think that's where, I was trying to note for the MAT project that we're looking to roll out. Hospitals have, I think, a strength in the ED and the resources. Some hospitals do have care coordinators, not all do. So under this ACH work, how do we make sure that all partners are working together and kind of moving in the same direction? And so before that patient is discharged from the ED, they've got a care coordinator identified, they've got an appointment with a community provider lined up, and that care coordinator is going to make sure that patient gets to the right place at the right time and make sure that treatment continues. So you're absolutely right. I mean, they are a huge component. So I don't see any more questions. I know we had,
I got one.
All right.
So this is one of the 9 ACHs. So could you tell us what your experience has been so far with the other 8 ACHs on your initiatives, if any?
Yeah. All right. I would say, so again, there was a lot of planning work that we brought ACHs together. We distilled down 5 or 6 different pathways that we thought were meaningful. We're now focusing on 3, and we're talking to other ACHs just like your ACH to try to see if there is interest and engagement around focusing on these pathways within kind of the healthcare-centric system. And then I believe in May 8th, we're meeting with the executive directors for all the ACHs and hope to have a similar conversation of, are these meaningful pathways for us to pursue as an association with the ACHs? I guess per the slides up here, we got through a lot of questions, so we've got that down. We're interested in suggestions from, this ACH as well as others of, has something not been calibrated right? Did we miss something? Should we rethink of the approach? And then, also if there's opportunities that we didn't think about that we should be thinking about. So I think we're looking forward to have these conversations with all the ACHs. We're excited that you guys are the first to have us out, so appreciate that. And think it's a great opportunity. And again, I think, we would leave it to this ACH, and we don't have to do it now, but, we would love your feedback from this community of, is this going to be helpful from a hospital and medical association standpoint? Have we missed something? And what do you see as opportunities for us to collaborate together? So I think we'd leave it at that.
Okay. Well, thank you. So Ian and Trish, I think, won't be able to stay because they've got an 11:30 flight back to Seattle. Is that correct?
I think we're hoping to stay for a little bit, but then, yeah, we...
Okay, so if you would like to, if you have something very urgent you want to talk to them about, just go outside and grab a donut and have that conversation. So I think that was a nice segue for what is next on the agenda. If we come up with some suggestions for WISHA, WISMA, that could be a part of this May 8th summit. We might be motivated, we might be inspired, we might be informed by what is you're about to hear from two of our own. And I don't know who's going to go first, whether it's Becky or Everett.
Hang out together.
Or together.
Is it all right if we break for like 5 minutes so we can get everything set up? Is that all right? Or
We can. So you don't have, either one of you have anything?
Online, so I just need a few minutes to get it all sorted out.
No.
Well, if you want to start getting that set up, go ahead. In the meantime, I'm sorry, I'm going to be kind of a taskmaster. I don't know if I want to break. Do people want to break? We can break if you want to take it. Okay, so please, 5 minutes only. So we'll reconvene at 10:15.
No worries, but perfect day.
Yeah. I was gonna say, when we put off the bank of, there's, that's good. Okay, Everett, let me give me a moment, I'll be right back.
Excited to see this. Really? Oh, you're gonna be down here with me, right? Okay.
We're gonna need to use this.
Need to use what?
Pardon me?
Oh, yeah, okay. I hope you like it. No, I'm sure I'll like it. I know. And then I'm like, I'm like, oh. Well, I got here.
To break this up. Hello? This is what happens.
Oh, yeah, we just stand here.
No.
Oh, thank you.
By the way, I'm not sure. Where you want to put it?
Can we take our seats, please? It is 10:15, and we want to give our speakers enough time for you to ask questions of them. So.
All right, have a seat, everyone.
It won't hurt.
All right, we're gonna lose the hospital people. Come on.
So I guess we're going to start with Everett Maroon. And Everett, besides being a Canadian by birth, is that it?
No, my wife is from Alberta.
Okay.
And she also got her PhD in public policy from George Washington University.
Okay.
So, my mom is from
Connections there.
Saskatchewan, so.
All right. And Everett comes to us from Walla Walla, and he heads up something called Blue Mountain Heart to Heart.
Thanks, yes.
So do you want to use this, Everett, or do you want to shout?
No, I'll talk in the mic, whatever you. And then, so Becky Gross, you all know Becky too.
I was going to introduce her later, but.
Oh, okay.
Sorry.
We're kind of together. We're not really.
We're the co-chairs of the opioid demonstration project team, along with Miguel and Chuck and who else am I? I'm leaving out some other folks. Good folks. Yeah, Walla Walla has had HIV Ryan Wright Part B provider since when we got started. I guess Heart to Heart got started in 1985. We're a 501c3. We're the Part B provider there, which is how we got into HIV prevention, which is how we got into harm reduction, which is how we got into opioid crisis response. So that's the short term of that. But what we want to talk about here today, and I think we're going to answer some of your questions from earlier, we've really taken a broad picture look at creating an infrastructure that is sort of reliant on cross-functional teams, not just within healthcare, but also looking at justice systems, social service networks, mental health resources, and I'll go into all of it. So this presentation, it might be a little wonky in places, so just bear with me. There are a couple like sample screens I just couldn't get out of the presentation, but they have beautiful MRI pictures in there, so I hope you enjoy that kind of thing. And I do just want to say, no offense to the previous presenter, but Alzheimer's patients can be very hostile and difficult and sometimes aggressive. And we come across all kinds of patients and clients who can scare us and be difficult to work with, people with, personality disorders. I just don't want us to tag opioid users as, this problem child, okay? Not that he was doing that, but let's just take a moment and reflect on, these are our mothers, these are our relatives and our friends and our neighbors who are facing great difficulties. Okay, so our objective is really to advance
opioid crisis response regionally in 4 core areas: dependence prevention, treatment, overdose prevention, and recovery. I'm not going to be able to lean over this thing. So we are also, because Chuck insisted, attempting to be inclusive of traditional public health strategies for tertiary, secondary, or primary, secondary, and tertiary prevention programs, and I'll explain how we're inclusive of those as we go. When we're looking at dependence prevention, according to Dr. Banta Green at University of Washington, our number of daily doses of opioids in Washington State in 2014 was approximately 104 million. This was down from a peak in 2011 from about 111 million. We've been making concerted attempts, but we're really not doing very well in terms of lowering those daily doses. So yes, as we just saw, if we're prescribing fewer opioids, we're hoping that we've got then down the pathway fewer misuses of it. And so we are strong proponents of the Olympic Community of Health 6 Building Blocks program, of better PMP use, the EDDI system, as we talked about, and other kinds of public campaigns for consumers, including drug take-back, getting out, locking pill boxes to people and their families, everything that's going to sort of shut down the initial pipeline. But where we really get into the heart of our response here is the creation of what we're calling the Opioid Resource Network. This is a case management reliant system that's really trying to link up better primary care and MAT resources. And we've got 2 ways of structuring this network depending on what's available in a given locality across our region. Okay, so there may be some places where we've got primary care folks who really want to themselves get involved in MAT in some form. And then we have other places where MAT is its own service that's going to be linked through a case manager into the support that the patient is also getting from a primary care provider. So, yes, this is, and we're not doing this because we think case managers are the bomb, even though they are. We're also trying to take the pressure off of primary care providers who are already overburdened and trying to get through their caseloads. So this case manager is going to do a lot of the work, including, if they need to, bringing the patient to the office, sitting in the exam room and helping clear communication between the provider and the patient, at least as they're getting established with each other. But they're also really the ombudsman for all of these other kinds of resources that may or may not be present in a community. Not everyone has a drug court. Walla Walla's is very new, but we're already seeing great outcomes from it.
Good job.
Yes, thank you. Thank you for being here, yes. So when we see comorbidities, we want to attach them to counseling, outpatient mental health support, housing support and placement. Housing is a real barrier for many people. We've got some use cases to look at later where we'll try and talk about that. Pain management and alternative therapies. As Melissa Cross, who's also works at Heart to Heart with me, we were talking on the car ride up here about, what was it, like 1 in 10 or 2 in 10 people could even get, any kind of acupuncture support through their insurance. So we're hoping to open up some pathways to, if we're going to cut people off or we're going to ramp people down on opioids, what other kinds of supports can the ACH help link people to? Recovery programs, education and workforce programs, harm reduction programs like syringe exchange, like wound care seminars presented by, drug court and diversion programs, as I said, and then peer support. And if there's something else going on in your neck of the woods that you think helps people who are in crisis around opioid use or dependence, then there's no reason why they couldn't become a part of this ORN that we're talking about.
Which is just meant to really just tie patients to treatment and give them the resources to stay in treatment.
Yes, exactly. So our first, we've got primary care as a separate entity from MAT, And then our alternate structure is when they are the same, when they're co-located. But it's basically the same kind of thing. I love the little hospital picture, so I had to put it in there. And Ian's not here to see it, darn it. Okay. So this is really, like I say, what we're talking about when we're talking about this structure. One of the things that we want to recommend that localities do in the ACH is really, as soon as they hit the ground running, an assessment of needs and gaps and what resources are present. Because if there is a piece missing from the puzzle, you know, we have to identify it, and then we can all together get started working on seeing how we can pick up those kinds of resources and services.
So basically kind of taking the responsibility within the counties to identify where the gaps exist. And part of the work is, you know, filling those gaps and reaching out and helping facilitate contracts and access to other services. Maybe it's transporting to another county to get the service. So it's basically kind of providing that point of responsibility to make sure that all the resources exist.
Well, and maybe transportation is key for this.
Yeah. Yep.
Well, I didn't put it in there as a thing, but yes, it'll come up in the use cases as you'll see, because some of these things might be provided straight through the case management service. So support for transportation could be, you know, something you get through the case manager, just like some housing support, utility support. We could talk about that. So our next focus is overdose prevention. This is going to sound a little bit familiar to what we were just talking about. It's primarily naloxone distribution, but also we really want to not just give people naloxone. We want to link them into supportive care, and we're happy to start with a harm reduction focus. If they're not ready to be in recovery, pushing them into a recovery program is not going to get us the outcome that we want. But we know that people who access syringe exchange are 5 times as likely to get into recovery. So they might not be there today, but they might be there in 3 months or 6 months or 9 months. We have to stick with them, and you know, we can give them some of these lower barrier services until, you know, and kind of keep them on the radar of these other parts of the network. So we would still like to see, you know, if they would be happy to, you know, willing to meet with a peer, that would be something that we could get them to do. If we could get them in to see a primary care person and deal with an infection that they might have before it necessitates an ED visit, you know, there's still a savings to the healthcare infrastructure there. So we want to really, you know, the way that Becky and I come at this is either you're going to present somewhere with an overdose. It could be EMS, it could be the hospital, it could be, you know, someone who's providing you another service, and while you're there, you know, someone at a halfway house or a shelter or something like that. But that presents to us an opportunity to try and link them into this network.
And part of this work is already being done by our own agencies, where we're out training sheriff departments and police departments and figuring out a way for EMS units to be able to hand out overdose kits at the scene of overdoses. And so we're already doing that work. That's something that we want to, you know, continue to spread out across all the counties, so that we can facilitate getting overdose kits in the hands of first responders.
Yes.
Which is something we're already working on.
Richland Fire just started a Leave Behind program, which is when they go out to a call and they suspect that there's reason to think that someone else at that site or location is at high risk of overdose, they can leave behind a naloxone kit for them. They just have to give me a little bit of information on, you know, what the demographics were for that person. And
Pasco does too.
Pasco does
that for a while. We have a system
Tacoma.
to replace the Narcan.
Yeah. But yes, Benton Sheriff's and Franklin Sheriff's, Pasco, Kennewick, Richland, all have had naloxone distribution made to them. Walla Walla Police Department, Walla Walla County Sheriff, College Place. We're doing Columbia County Sheriff's next. So, you know, naloxone is already getting pretty well distributed. Yeah.
Okay, so naloxone and Narcan is the same medicine.
Narcan is a brand name of a specific type of applicator of naloxone. Yeah.
And we anticipate also continuing to work with the hospitals like WSHA does in promoting the use of the overdose kits. And I've done that here in the Tri-Cities already, and it just takes somebody coming in there and just doing it. Let's just facilitate a conversation, have a meeting. Why are we not handing out overdose kits in the ED?
Right.
You know, how do you do it? Well, pharmacy has to prove it. Okay, pharmacy, let's meet. Let's talk about it. Let's get it going. That's really all it takes.
Right.
But everybody's waiting for somebody else to do it. So, you know, that's part of, you know, our role in doing this.
Yeah, there have been all kinds of interesting questions that people have had about giving out naloxone and the legality of it, and, you know, we keep coming back to, you know, just education of those partners. Yeah.
And I'm not trying to draw this out, but just a question. I know that when my brother-in-law was on end-of-life services, one of the things they gave me was the Narcan to keep in the household, just in case there was an overdose, that I could use that. But the question is that how can, outside of that, how can I get a hold of some to keep with me? Because I do have interactions with low income and homeless.
Well, as soon as the Pasco syringe exchange opens up in the next couple of weeks, you can walk right in there and get naloxone. I love you too. Okay. But as you see here, what we're really trying to do is walk across these different silos that we all find ourselves in and make some bridges for communication. One of the best things I think people can do is create advisory boards in their own localities around the question of opioids and opioid crisis response that can really pretty easily interact with this network. So we've got syringe exchange staff. If we're seeing stuff, we have no reporting, you know, mandates. You don't know what our numbers are unless we tell you. So sit down in a room with your syringe exchange managers that are operating in your area and ask them, how many are you giving out? Who are you seeing? What's the demographic breakdown? What's going on with them? What kinds of drugs are they reporting that they're using? You know, we need more information, not less, just because some of these folks that go to syringe exchange, you might not see at the hospital system or in the healthcare system for a while. Let's get them earlier. Yes, emergency department, social workers. You know, this will foster better connections with them in the way that Ian was talking about earlier. That's exactly that piece right there. MAT specialists. These folks can help stabilize these patients through the provision of Suboxone, methadone, Vivitrol, whatever it is that they're working with. And we need to be hearing from them what's going on with these patients and what's going on with the population. Drug court officers, my new best friend. You know, what are they seeing as they're adjudicating cases? What new trends are there? How can we work together better? So we know that we'll do a better job supporting these patients if we break out of the box a bit. And I understand that this is kind of a hard piece for some folks to think about because we are so, you know, I need a lot of education on what hospitals are like, so I appreciate you, Melissa, for telling me. You know, and other people really don't know, you know, what is our diversion program trying to do and who's working in it and, you know, what's going on there.
Yeah, and another piece of that is there's quite a bit of overlap in some of the justice initiatives where we're trying to do the jail diversion and we're finding folks with substance use disorder in the jail. What are we doing with them? You know, they're leaving, they're overdosing because of their tolerance level. And so, you know, we need to incorporate working within the jails. Right. We need to be at the table of these justice initiatives so that we're not overlapping and that we're actually collaborating. So there's a lot of opportunity just within the justice system. Yep. And also
out of recovery programs.
Yes, out of recovery, therapeutic sentencing in place of, you know, continual punishment. That doesn't seem to be working. So there's obviously potential.
Do you have a question?
Has there been any discussion at all about providing support and mentorship and education for primary care providers separate from the pain guidelines? For example, to navigate step by step how to deal with the inherited chronic opiate patients who are medically complex, and you have a primary care provider whose time is completely sucked up by management of this medically complex patient, and how to navigate that, and how to even have that conversation with this patient who's been on opiates for years, all prescribed, and now you're telling them that you have an opiate use disorder. That's very complex, and there's not a lot of help out there for providers. At our clinic, what we've done is engage the help of an external peer reviewer, but that's a drop in the bucket. And when you see what comes back, several pages of recommendations where we have mid-levels that haven't even, in their education, have not even been trained on chronic opiate prescribing.
That's what this person is for. That's what this case manager is supposed to help you with. If you come on in and help you do it, or basically do an assessment on that patient and really look at what can we come up with as an individual service plan to stabilize some of the other barriers and complications for this patient that then we can support you with as a clinical provider.
I think you're talking about hundreds and hundreds of patients within your large clinic.
Yeah.
Because we're dealing with a lot of the same, very complex patients. And my hope, I don't have an immediate answer for you, but my hope is that as we move towards this behavioral health integration, that will begin to address those folks that have the underlying mental health. Because right now, we, as primary care providers in the clinic, we're doing what we think we need to do, is prescribe these opioids. There's no assessment on risk for addiction. There's no, we're not integrating underlying mental health to make sure that patients get referred. And then we have just the resistant patient that's, you're banging your head against the wall.
Right.
Because you don't know where to go from here.
But I'm saying that, providers need a lot of support, even for the medical.
Yes.
You can't tease out just the mental health and the, substance use disorder part. They're all intertwined, and they need somebody to say, this is what you do with the diabetes while you're doing this with, the spine issue and this.
But so that's where, if we were going back and talking about Part B support for HIV positive patients, the case manager would look at, well, what's their home look like? How clean is this home? Are they getting infections they don't really need to get because they need more support, or they need to be moving to a place that's, hygienic for them or something like that. And then we can alleviate some of what comes up for them, or we can say, I'm really excited that you're adherent to your MAT or your ARVs or whatever it is, but you're really not, your eating isn't good and it's hurting your diabetes, and you can't do this with your insulin, and, really stay on top of some of the other things that do come up for you as a clinician, but really be able to have those longer conversations with people to try and work around.
We hope to have we're at this point, we're coming up with ideas.
That's our bread and butter with HIV right now. So
this is so huge right now. We haven't done a complete assessment to figure out what we're going to apply as an intervention in all the counties. But this is our idea.
Right.
And I'm hoping that we'll have some sort of you can pick up the call and say, hey, I've got this person that we think has an opioid use disorder. Can you help us? And we can provide outreach. Maybe we can attend that appointment with that patient and help you walk through that. But it sounds like a lot of what you're talking about is just general case management with chronic and complex issues.
So,
primary care.
This is a good role for the ACH because we do have funding set aside for workforce development. So I think for clinicians that are interested in learning more and having more resources to do that, I think that's the role of the ACH can play.
Yes.
So we work in wraparound services for youth, and those youth have a lot of complex issues. But the thing is that when you have a patient that buys in, that's the biggest piece. That's the biggest hurdle to get over, is that buy-in. So when they partner with you and you're able to have these conversations, you're able to give them that guidance. They're going to be walking into those doors more often, more frequently, and they're going to overall do better. What I'm seeing is kind of modeling that wraparound thing, because we're talking about a whole person. And it's just this one and this one. Oh, we'll take a bus ride right across town, get this paperwork and bring it back to me. and then we might be able to help you with something. So it's not sending them off, it's like giving them an opportunity to be within a program that's going to support them. That's the buy-in. Once you get that partnership going, you're just gonna see a lot of growth. And it's just gonna be a continuum, and I think this is wonderful what you guys are doing. Because this is something that I would have loved to have seen years ago.
This is something we've been pushing for years. But yes, we're glad to have an audience.
I have a question based on the term that you said, the risk for addiction assessment. I've heard of that recently in the maternal child area. Have you come across a quick 1 to 3 question assessment that you're going to incorporate not just in the ED but in other areas of care?
There is a tool. There's a tool that already exists called the opioid risk tool.
So,
But I've been doing this for a while and I've not seen it being used.
so is that part of your plan? Is to use a common, like they do risk assessments for all or something, or even the department scale, something that is doable in multiple locations, maternal child as well as ED, clinic.
So we haven't really been leading with that. One of the reasons is because of the stigma around opioid use. So, I just got handed to me at the board meeting Tuesday night a new questionnaire from a local provider in town that's asking for people who are new patients trying to get connected to a provider. It's a questionnaire about what, Melissa, like 6 questions long or something, and it asks about every single scheduled narcotic out there. And then what I heard from the person who gave it to me was they're using this to say no to new patients. So all you're doing there is killing the potential trust you would have with a patient. They're not going to answer you honestly. And what are you doing as a provider then if you're not working off of a realistic understanding of this patient? So I think one of the things that we need to try and do, if people really aren't ready for treatment, if they're not really ready yet for MAT, and we're trying to meet them where they are, maybe all we can do is teach them, better ways of injecting so that they don't get abscesses. And then hopefully that down the road, we can get them linked up to a provider. So we're trying to meet people wherever they might be in this use cycle of theirs. But I agree. I just think it's hard to boil everything down to a questionnaire that people can use. That's why I find that a trust relationship with a case manager really cuts through a lot of the concern that new patients will have, and you'll get really good answers out of them. So you have to have a good comprehensive assessment.
Are you talking about a questionnaire to assess the presence of addiction?
No.
The risk of, yeah. So,
okay.
Opioid prescribing. Yeah, so.
And then it would be generalized, so it's not stigma on anyone. Actually, if you look at it, we're all at risk.
We have an ORT, opioid risk tool that's in place. But like I said, I don't see anybody using it. So I think in part of the appropriate prescribing that WISH is doing, along with the AMDG prescribing guidelines that was just updated a couple years ago, it incorporates the risk, that piece of assessment as you begin the prescribing for chronic opioid use and acute opioid use. So it does exist. I don't see it being used.
Okay.
But it doesn't exist.
Yeah.
Risk for potential for addiction or global addiction doesn't exist.
Yeah. But I don't see like primary care when they initiate it or.
Okay, our 4th area is recovery. And this is, what we're trying to guide everyone into through the network. So it's really linkage into recovery programs and MAT long-term, not just, sticking around for 60 days with them and then hope they, float off into happiness or something. We're looking for improved retention and some expanded time in recovery programs. So there's no reason not to be talking to the ACH about, hey, if Medicaid's only going to pay for 30 days, how about if our ACH pays for 60 days? Get people, into those programs much longer with support. Because we have a long way to improve. We had 700 people enrolling for the first time in 2002 and then 3,279 in 2015. But look at our numbers of folks misusing pain relievers, all pain relievers in Washington State. Look at the numbers of people nationally. We can do a lot better. So I kind of like having this as one of our metrics because I know we can do very well on it if people really get involved in this network structure. And again, the point of this network is to be flexible and scalable across the 9-county region. So, you know, Walla Walla does not have a recovery cafe. This is the Seattle Recovery Cafe up here. And I just note for a minute who's sitting in that room, right? I keep talking about grandma because grandma is a big opioid user. But, you know, we have other folks who are helping people stay in recovery, transitional housing like Oxford houses, you know, Suboxone providers, counselors, inpatient and outpatient, all kinds of folks can get involved. I think Walla Walla has a Trilogy Recovery Community. They do a lot of work with recovery success and prevention. So however these things come together, we want to be able to make referrals and hear, you know, what kinds of programs they're doing, how are their programs changing over time, how can we keep people, you know, to remain involved in these kinds of programs. And we look at we have some use cases here. This is where I think my,
You're fine.
okay, so where I think my thing might not really work right. But I think we're just going to see Kathy's name really big in a second, and that's not really what I was intending. So we might have to come out of it, but let's see. Okay, here we go. Kathy. Okay, so here's Kathy. Opioid user for about a decade, young adult, has lost access to her parents' insurance at age 26, hasn't picked up insurance, has turned to injecting. She's not technically homeless because she's couch surfing, so she doesn't qualify, but she does access the syringe exchange. She's got a couple of ODs. So how could we help her? So pulling from the things that we had in our network earlier, we can support her with insurance navigation, case management, care coordination, wraparound services, including transportation and food security, and that could be vouchers for a food bank or gift certificate to Safeway or, you know, something else. And then MAT and a CD assessment, give her naloxone. Everybody gets naloxone. That's Chuck's thing. Give everyone naloxone. Linking her into preventive and primary care, giving her counseling, and then working her plan with her. What are your 3 goals this year, Kathy? What are we going to do with you this year? She might have 14 things in her comprehensive assessment, but you know, none of us achieve more than 2 or 3 things a year for ourselves, right? So we're not going to dump that on her either. And then, you know, referrals to, she wants to get back into working. We'll help her with that too. We've got someone like Derek, an older person who's overusing OxyContin and hydrocodone and doesn't want to, and is starting to change the answers he gives to his provider because he's afraid of getting cut off from his meds. So when we see different kinds of pieces that the case manager can employ to support Derek. Again, there's the naloxone, and you know, a lot of these, you know, there's a lot of overlap, but then we have like underlying behavioral health issues. You know, let's look at that. And here's a, you know, we will have a discussion with the prescriber about what's going on with his prescriptions and does he have emerging OUD and what should we do to try and support him, support the pain, but also not let him sink into total misuse.
NCO.
Okay. Hi.
Can you mute, please?
And then we have Janelle, who uses a variety of substances, but including an opioid, heroin. Also has hepatitis C and HIV, is homeless. We can use some HIV resources for her, obviously, if she has that diagnosis in Washington State. She's got some justice involvement and an overdose. So we can, you know, bring another suite of services to help her. But in every case, we're linking into healthcare, we're linking into MAT, and we're doing the bulk of the support for that patient to try and help them be their best person for the provider, so that they can really work on their continued improved health.
So it's not just a one fit for everybody.
Nope. No, everyone gets a individualized service plan, an ISP. Yeah. Then this is really how it fits in with a public health framework, where we're looking at education, we're looking at initial interventions like harm reduction and naloxone distribution, and then we're looking at long-term prevention and improved community health through improved individual health. Any questions about that? Okay. And then this is where I get into these funny little slides that I couldn't get rid of. So just try not to get dizzy. See, there's a nice grandma there. That grandma is on opioids, I'm telling you. Okay. Where's the MRI picture? Okay. And then basically this cross-functional team approach here is exactly what we explained earlier. So really trying to look beyond just healthcare and bring in folks who are also providing services and responding to the opioid crisis more generally. And I know we'll meet our numbers goals. So other questions? You should get the microphone too, Becky.
No,
Okay.
So why don't you two stay up here, and let's open it up for a broad set of questions. And I just want to seed this a little bit. We've got several public, since you ended with some public health references, we've got several public health districts represented here. Can any of you chime in to see how this would fit into your activities? Who wants to be a brave person from Walla Walla, Benton, Franklin, Yakima?
Oh, yeah. Thank you.
In Franklin County, and we are currently under discussion looking at other funding opportunities for that as well. We connected throughout this.
I talked to Carla and Rick and gave them all my best words boilerplate on syringe exchange. Oh, good. Okay, good. All right.
Any other counties want to weigh in? Yes.
The struggle that we have is basically trying to keep our head above water just because of the current requirements we have for foundational health. And I guess I think it's important that we really look at core funding so that we can have those educators in our department to communicate with the whole spectrum of in our counties. Your reaction about, here, go do this, and then, no, funding's gone, you go do this, no, funding's gone.
Right.
It's critical to keep this
Right.
alive and well and effective.
Well, Becky and I have had this conversation a number of times.
Repeat her.
Oh, yeah. How do local health jurisdictions get more robust long-term support for the hard work of education that they need to do, not just in the moment where opioid crisis response is fashionable, at the policy level, funding level, right? Is that about right? Yeah, one of the things that we've talked about a lot is if you go and look at UW's data on drug use, illicit and illicit drug use in Washington State, yes, you see a lot of heroin use and a lot of opioid use, but right behind that wave is an increasing wave of meth. And there is no cultural sympathy for methamphetamine users like there is for grandma, which is why I keep talking about grandma, because one of the things we're trying to do is really try to move the sympathy, not away from opioid users, but get it to include alcoholics and meth users and barbiturate users and drug users in general. Because I think we really need to at some point be expanding the conversation from, how can we move opioid use away from simple incarceration and justice involvement and into, mental health and integrated health and right. And then how can we do that for all drug users? So, that's a longer, that's not what the ACH has money for.
And enable providers
Right,
to have that conversation and feel comfortable having that conversation with their patients.
right, yep.
Okay, so here's a comment from Kittitas County, Dr. Kevin.
So actually, it's a question. Do we have data looking at how many of the opioid deaths involve concomitant benzodiazepine use?
It's certainly captured by coroners. I can ask Caleb Bantagreen if he's extrapolated the data, really sort of pick them apart for that. I know when I look at the Walla Walla County data, nearly everyone who overdosed from an opioid had something else in their system. A lot of the time it was a benzo of some type.
So just thinking from the primary prevention standpoint and education, that might be a useful data point to capture.
Sure. Yeah. So Kevin, part of the data set that we have access to, it's become very granular, stratified by ethnicity, by age, and by other diagnostic categories, and to look at not necessarily deaths, but concomitant opioid and sedative use. Right. So which is obviously a precursor.
Right.
So
I think it multiplies it 4 times the risk.
I was going to say that becomes a numerator.
Yep,
and
4 times.
That would be interesting.
Just this morning, there's a pain conference across the street, chronic. So I sat and listened to a chronic pain management provider from Lynx, and I was surprised to hear him say that when they bring somebody on and they begin chronic opioid management, they immediately wean the benzos. Okay, now I don't see that. I'll tell you, I don't see that. I look at PMPs all day long. I see, I see diazepam, lorazepam along with the opioids. Now, it may not be prescribed by the same provider. It might be prescribed by a behavioral health provider who's not aware of the opioid prescribing. So that becomes a communication issue.
Right.
But it's definitely increased.
There's also been 2 syringe exchange surveys conducted by UW, one in 2015 and one in 2017. And I think they had 21 of the 25 participating, or SEPs participating in those surveys, maybe like 1,200 responses. And they asked people all the drugs they've used in the last 3 months, the primary drug they've used in the last 3 months, all the drugs the last 12 months, and primary last 12 months. So there's good data from, pretty sizable N there. And those are people who haven't necessarily overdosed. So that's, I think the bias there is who comes into syringe exchange to answer a survey versus who doesn't come into syringe exchange.
Yeah.
What you were just saying, so I have chronic pain and it's my list of medical issues, but on occasion I have to get assistance with that chronic pain. I'm not an addict, but I know what it feels like coming off of them in transition because I have to have something else done, have to be on them for a specific amount of time. But my sleep pattern gets interrupted by the use of the opioids. And so my doctor does prescribe me with the diazepam. But in understanding how if you take the opiate and that at the same time, that it does rise up. So in between that, if I'm going to sleep, I have to take the medication early on. And then at bedtime, use the diazepam.
I think the key to that is making sure that you have one prescriber who's aware of
Right. And you're educated about your medication.
The same pharmacy and having a plan.
Yeah.
That plan to end that and get the treatment that I needed, that was the important piece. Because I could self-manage beyond that once those big things are taken care of.
Good point, good point.
So can I hear, Megan?
You asked about how the county perspective this work. I think it's really critical. And you didn't mention the opioid symposium that's in Walla Walla on the 15th of May.
We changed it to the 7th and 8th of June because Providence doctors couldn't come to the CME training the night before. Okay, Providence, thanks.
This is a system level change. It involves so many different partners within the community, so much informed so that, and locally too, I mean, it's great at the regional level, but it needs to happen locally, so that, because there are silos locally as well, and we need to make sure that this work is, that everybody knows kind of what's coming, so that pop-ups don't happen that aren't connected to some of the broader work that's being proposed.
So Megan, in terms of your community event and other important community events that relate to this topic area and other topical areas that tie to our work, please let us know about those events, because we will post those on our website. We have a place where we list out some of these important events that people can get more information.
We're also going to provide breakfast
and our
lunch.
newsletter.
Yeah. Thank you, Megan. Yes, sir.
I would like to compliment you on the new website.
Which website?
What new website?
The ACH.
Oh, yeah, there you go. Oh,
Yeah.
great. Yeah, that's it.
All right.
There's so much useful information there, including, the schedule for these meetings. I also wanted to say, in connection with the presentations today, will they be on the website? That was one of the nice things that I found there was a recording of what had happened in this room, and also some of the presentations were available there.
We saw some heads nodding over here.
The recording and the presentations will both be made available.
And then one other thing, one of the things that I learned today is that, in a way, the problem with opioid prescription opioids has peaked in terms of this trend to prescribe too much opioids. But there is a danger that patients will turn from prescription opioids to the illicit opioid market.
Correct.
And so I think that one of the things that you as a community need to do is make sure that people understand the success that has been achieved in stopping the growth and slowing down the growth in prescribing too many opioids, and that this is kind of the next step. But we've already achieved a part of the goal, which was needed because of this explosion in prescription opioids. That's why we've got such a big problem. In a way, we've got we're halfway there, and we've stopped the sort of the source or the first cause of the problem, and now we need to address the remaining problem because so many people are using so many opioids.
Well, we admit there is a problem, which I think, that's what we tell people who are dependent on substances all the time, that they have to do first. So,
Yeah.
But yeah, I went to the White House convening on opioids in 2016, like 3 days before the election. It was a crazy time in DC. And there were a lot of people there. West Virginia has the vast majority of folks at that meeting of like 130 people. And part of what really needs to happen is we have to agree to try something. We have to agree on a strategy or a number of strategies. We can all identify there's a problem, but if we're not thinking that has the same root cause, we're going to come up with very different kinds of strategies, and we can really spend a lot of time twisting around, So what I really like about this approach is it is a concrete strategy, but it does respond to what's going on in local communities so that people can do what works for them. It's not a one-size-fits-all. It's not just low-hanging fruit. There's hard work encapsulated in here. There's years of work, but I know that we can get enough folks interested. In that 2017 survey I talked about, 78% of the respondents said they wanted to do something to lower their use or get into recovery. Now, people will say they want to do that and not really be prepared to do that. And the respondents is a pretty sizable number. So even if we are starting with, a percentage of that 78, I know we'll be able to assess our outcomes very well just going through this, process of the ACH, yeah.
How long before you launch this?
Ask Carol.
Carol?
We're working on it.
How long before launch?
So can I put the question out again to Yakima specifically to find out what is going on in your county? You are the second largest metro area in our ACH, and it'd be really important, I think, to find out if you want to respond to what you just heard from Becky and Everett as to what's going on, where you see some opportunities, where you see some challenges with in Yakima County. So not to just look at you, Sandra, but I mean there are many others here.
Well, we have a needle exchange. We have a needle exchange in Yakima, and we've had one through the health district.
Okay, and?
They're doing some naloxone provisions through the needle exchange, but frankly, you need more hours of operation for that needle exchange. And Heart to Heart has been tasked with trying to help. So, as part of our SAMHSA grant for this naloxone infrastructure improvement work, we can bring more in and we now actually are getting I haven't said this publicly yet, but we got a grant from the state Department of Health to buy a van. So I know. I signed the loan paperwork last night because, you got to spend the money to get the money. Thanks, State of Washington. But we'll be able to site, in West Richland, or, in Yakima itself, in Dayton, in Clarkston, and get, do much better coverage of syringes. I know it's not 4 days a week or anything, but yeah. So talk to me if you're interested. I know. Yeah, it's true.
Anything else from Yakima? So those of you who are providers in the room, we heard some of the challenges of bringing providers up to speed on a variety of skills to deal with this, and your response was case managers. Does anybody else have thoughts on this role between case managers and providers? Whether they're mid-levels, whether they're PCPs, any thoughts on how that might work?
Hi, this is Deborah Rogers.
Yes.
Deborah?
Yes, and I'm a provider in Tri-Cities.
Yeah.
I have sometimes been very resistant to send any of my patients to pain management because they quadruple what they're getting. And I have been trying to keep my patients very low, like 22.5 milligrams a day, pill equivalents. I have not really felt support from either case managers or emergency rooms.
In what way?
I have had patients who are on very low amounts, mid-50s, arthritis, diabetic neuropathy, etc. And I'm trying to get them to lose weight, etc. But they've been treated like drug addicts in the ER.
Yeah, they're not providing additional pain medications if they're already receiving it from an outpatient provider, unless they present to the emergency room with some objective finding.
Oh, exactly.
So they're referring that patient back to you for that discussion.
No. They go to ER for chest pain or another issue, but they'll write opioid abuse on their record.
Oh.
This is true.
Okay.
Which is sad. Because we tried really low doses.
Yeah.
All right.
Everybody's scared.
Right. Do I see Mark? You want to say something, Mark? From Providence.
Yeah, perhaps maybe another perspective on this. There's the assumption that in a big building with four walls of the hospital, there's apartments talking to each other. Not true. Very silent.
We know.
So we have having individuals running around called case managers, really discharge planners,
right.
To get them off campus and community resources. But it's sort of like happening at the time that this goes someplace that, we're looking at Carol on the left and team, right, for these counties to be that blue. So what we're finding is
pull all this together. And historically, it's been an expense work and not really supported, but I think the value of case management, care coordination is going to be elevated. It's going to help the physical, behavioral health, and substance world to try to bring that together. I'm saying that we have an issue with how we get data exchange. That's going to be the real important piece for it. And I think that much like in the practice transformation group that Carol and Wes talked about first, adopting that patient-centered medical home approach is not just the pharmacist and the level, it's care management. They are the real key.
Yeah.
Great. We agree with you, Mark.
Yeah.
It's critical.
It's about time. I've been doing it for 22 years. I've been waiting for this day. Yeah.
We have to do a miracle for ourselves because we haven't invested in that resource, and now we're trying to catch up ourselves.
Yep. Right.
And then connect with
But the good news is I think most people will catch up rather quickly. I think when you get a competent service involved, I do think, you know, we can make some headway. It's not rocket science. It's paying attention, and it's making those relationships and partnerships happen. And once you have something established, you know, it works really well. Nothing's perfect, right?
I mean, again, the projects that were chosen by Greater projects chosen by Greater, there's so much overlap from all the projects that are available in the domain for any of these. Right, so that's all vertical. So how do you try to, you know, connect all those dots with the environment? That's one. Second is the FIMC mandatory project is going to help the state of Washington because it's a waiver of demonstration of the state. Because we have to do it. How we do it.
Right. There is one barrier that we haven't talked about here that our network doesn't really address because it's sort of the solution to it is far outside the ACH's reach, which is when we're talking about pregnant women who are using it. But we have to do something about statutes and criminality of, you know, pregnant women using, you know, misusing illicit or illicit substances. I don't really know how to correct that problem without getting assistance from the legislative side.
So I just, one point about case management that I think we need to think about is we've traditionally used case management. We've got hospital case manager, then we have a behavioral health case manager, then we have a housing case manager. We need the patient's case manager.
Right.
That weaves through all of those levels and has the facts.
Right.
That speaks on behalf of the patient and is the patient's advocate and helps facilitate care. I mean, I think until we move to that model, we're still going to have silos. Yeah.
That's why we're so interested with small and
and many of our other service lines, we stand people like that, we call them patient navigators.
Right.
Whether it's cancer,
right.
Cardiology, whatever it might be. So that's
yeah.
Right. Focus. So.
This is a bigger spectrum.
Yeah.
Yes. Yep.
And one of the things that I know, the model I tend to use is clinical folks being that patient navigator, because it really needs to be someone who understands the medications, who understands the implications of ejection fraction on a heart failure patient, who understands a really bad A1C, who can then put the pieces together. So the navigators are great for care coordination, but in terms of case management, I think they really need to have some medical knowledge.
Okay, so good thought.
Yeah, that's great. That's good.
So one of the possible solutions might come to this issue of case management and its integration into complete patient care might come from MCOs. So I'm going to put some MCOs on the spot and see what have, we have several in the audience this morning. So what have you been talking about within your organizations about these very issues that you heard today from all our speakers?
And we have been interacting with some of the, I'll take it first because we're looking at you and everybody. I think the main topic is joining all of this work which we have. The other topic is changing some of the practices that the MCOs do regarding what can be called assisted treatment and when to allow doses. So every MCO is approaching that a little differently, but always with the goal to improve the situation. So I can speak for Molina, for example, where we have changed some of our prescription authorization practices to reduce the number of cycle prescriptions or refills in order to reduce the opioid and include more of a conversation with the primary care doctor or whoever is prescribing a little too much to do that. The other thing we're doing a lot, and I can share, there's an article that just published this week on Washington Healthcare News that was written by our CMO, Dr. Francisco Molina, just explaining how we, the MCO, or at least Molina, is changing some of the practices. It probably illustrates it more. It's a lot of changing prescriptions after doing some analysis and doing a lot of data mining, quite frankly, in who's prescribing, in which areas. We've done some data mining. To give you an example, not here, but Olympic Peninsula, Pierce County, there's a lot of crossover on prescriptions that when you look at that in front of the map and heat mapping those members, prescribers, you see a lot of strange stuff. So we're looking into that, and in consequence with that, we changed some of the authorization practices. That's kind of the overall. So I'll be sending, some of you have already received it, but I'll be sending that was published just this week.
Okay. Anybody else want to weigh in? Caitlin? United?
I think that for all of what Marty said, yes. And I think as we sort of transition into integrated managed care, there are some changes we need to make on the treatment side to help with a lot of this. The way that ASAM criteria is set up, it only really incentivizes residential treatment to help treat, and that's not always the best way for a client, and it's not client-centered, and it's not a recovery-oriented model in that case. So trying to do some work around how we allow STD providers to be able to do intensive outpatient treatment more for different kinds of clients with opioid use. But I think that's one of the biggest things too. Us at Amerigroup actually partner very closely with Consistent Care to promote this model of kind of how we address the opioid crisis in Spokane and here in the Tri-Cities.
Yes.
Yeah, Andrew, it's pretty good. The only thing I'd say ditto to my and Joe Pollock. The only other thing that was coming out when you guys were doing your presentation, a couple of notes is, I think during Wisham's presentation, they were talking about how they want to provide data so that their providers in their hospitals and their clinics can actually see what their prescription practices are. I think it's the same thing. I know we are doing the same thing as well as providing that data to our contracted providers so that they are aware, like, wow, I didn't realize I'm in the top quartile of, opioids, or wow, you're doing really well. So I think it's being a partner with our providers and providing that data. So I think yes on that. And then the other piece is when you're talking about case management, totally agree. I think we all have case managers and health homes and outside of health homes, just case managers, how we utilize health workers and licensed clinical staff. And so I just think how we coordinate with other efforts, making sure there's, that duplication isn't happening, or if there is the case management program that you're in, that we're also aware of that and a key partner, because maybe they're also engaged with us and you don't want to be duplicating. So I think those are kind of the things that came to mind as expectations that I want to call out.
So my follow-up to all the MCOs here in the room is, how do you see yourselves working with this model that's been presented today by these two people?
United.
Oh, so United, sorry.
You can finish that question. I don't know that we will, but we really definitely want to be involved in this. We have our own case managers as well, and we see that we don't want to hold them level. I think there's some work we may need to do around support and how can we rearrange, because if we already have all these case managers, how can we help funnel them into the system so we're not doing that duplication? As Caitlin mentioned, it'll really come down to how IMC starts working and how that incorporates into this. So, as we see more of the project design, as we work more closely with those behavioral health and STD providers, we'll see how they want this to work.
Okay. Well, let me turn the question around then. How do you two see this program or this model working with MCOs?
Saving the money.
Saving the money.
I mean, I don't mean to sound flip. I mean, I think there's too much pressure on the entire healthcare system because of how far along some folks have gotten and how overutilization has happened. And I think when I say case management, I really don't mean care coordination. I really don't mean insurance navigation. I mean sort of intensive client support. and bridging to providers in order to facilitate, you know, effective relationships to improve individual health. But so I think, you know, what we offer MCOs, and Jorge and I have talked about this a few times, is you know, really being able to look at risks for you know, for certain kinds of health events before they occur, and, you know, facilitating a trust relationship on the part of someone who's at risk for a whole host of events, and working on, you know, stabilizing that person so that when they, you know, so that they can have better health and avoid some of those things. If we can avoid any overdose, we're going to save that much to, you know, to people's time and the cost of service. And, you know, I mean, for every $1 you spend just on syringe exchange, you save $7 in healthcare costs you don't need to deliver. So, you know, that's just one tiny piece. That's not even case management. So I think that's,
yeah. Well, I think we're already seeing really great interest on the part of the MCOs to try to shift that care coordination, case management piece down to the local level, and understanding that the key is really us going to the patients and not waiting for the patients to come knocking on our door to come seek care, where it's this outreach model. And I just think it's going to be really important for the MCOs to understand what's going on. I mean, you're a big entity across the state, got a lot of lives to manage, and it sometimes can be really challenging to understand what's happening at the county level and have representation at the table on these smaller local initiatives that are happening, and not lose sight of the importance of being a part of the answer at the smaller level. That's
okay. And I just want to apologize to those people who are not familiar with this acronym. Ed brought it up to me during the break that we should really spell out some of these acronyms for those among us who aren't too familiar with them. So MCO, Managed Care Organization, that insure the Medicaid population in the state of Washington. So, Ronnie, we're going to have to wrap up here in just a couple more questions, and then the last word from the staff.
Sorry, I know that your question went out to them, but one of the questions I had was, is there a referral process, or is it self-referring, or is it insurance referral, or is it hospital referral? You see in the system of care that there's this data coming out about a patient, and the insurance is saying, hey, we're paying for this, we're paying for that. How can we utilize this service? So maybe the insurance would reach out to you. If it's the hospital itself, getting a chronic patient coming in, or clinic, is the referral coming from them to you? How are you getting the clients?
What we put in the project plan that was delivered months ago now is multifaceted. So if someone can walk into a syringe exchange and say, I want to get back into healthcare, and so, you know, they can enter that way. Someone can have an overdose, and Becky gets an email saying, you know, here's a new, you know, ding ding, go see this person. Someone can be recommended to us from a diversion program or a drug court as part of, you know, their adjudication through that process. There's going to be a whole host of ways. And what you mentioned earlier, you know, release from prison or jail, you know, someone departing a recovery in-person or inpatient recovery program where we know there's a risk associated. But we could also have, you know, individual physicians say, you know, I'm looking at this patient. She's been my patient for a number of years. She's showing, you know, that maybe she's an emerging OUD case, and I think she needs more support. They can access the network that way. So we really want, you know, we're not just looking at the case manager being the person that ties all of this together. We're looking at all of those entities, knowing there is a case management service that can help pick that person up and get them, you know, supported throughout the network of providers. So it really will work both ways. We want to be able to kind of make an agile network, you know, it's going to identify people who need extra support or more support or access to the program.
Thank you.
Thank you. This is one of the 4 project areas of the ACH, and I don't know whether you two are soliciting more help on your committee,
Sure.
but I imagine that might be something that you would welcome. So go ahead and see Everett and Becky after we break here, and see if you can get involved. So with that, I'd like to give them a round of applause. This is good. And now, before you leave, if you wouldn't mind doing one more thing, and that's just going to menti.com on your smartphones, type in the code, and please answer 2 questions. And these questions are sort of just a self-reflection on what happened today for us staff, but also where we might go in the future. And so you'll see with the 2 questions. So once you've done that, you're free to go out and enjoy the sunshine. Thank you again. We will be meeting next month. It's on your agenda. Is it May 17th? I don't know.
Third Thursday in May.
Third Thursday in May. So thanks to all of you online or on the phone. If you can go to menti.com, and the code is, don't cover that, please. The code, if you want to do this, is 784062.
Hey, Wes, the board meeting is not here, right?
That's right.
It's over at Martine's place, right? Okay.
Can I ask you a question?
Yeah.
Oh, okay.
We actually told this week.
Thanks for coming today. Good